Hello, everyone. It's noon. We'll go ahead and get started. I'm Alison Bond, the Medical Director of Medicine Grand Rounds, and I'm really excited to announce our speaker today, who's Dr. Margaret Fang. A little bit about Dr. Fang. She's a professor of medicine at UCSF Health, and the chief of the Department of Medicine, Division of Hospital Medicine, the medical director of the Anticoagulation Clinic here at UCSF Health. And she's a clinical outcomes researcher that's focused on optimizing anticoagulation use, balancing risks and benefits of anticoagulation. She's on the advisory boards of the National Blood Clot Alliance and the North American Thrombosis Forum. And I'm very excited to hear about all of the clinical pearls that she has to tell us about antiplatelets and antithrombotics.
Thank you. It is so exciting to be here to talk about my favorite topic, which is antithrombotic therapy, anticoagulants. It's wonderful to see really friendly, familiar faces here in the room and online. And I love the topic of anticoagulants and antithrombotics because as a clinician, there's very few more vexing situations than when you have to think about this therapy that could have terrible consequences if you prescribe it, or terrible consequences if you don't prescribe it, and it's all mediated through clinicians' experience, judgment, patient preferences, shared decision-making, all of that. So this is why it is such a great topic. And I will say that after 25 years of working in this, I still, every single time I prescribe an anticoagulant, have this kind of sinking feeling thinking, I am making a terrible decision because what if they have a terrible bleeding event because of something I did? And every time I choose not to prescribe it, I'm also having that same sinking feeling like I'm doing the wrong thing and they're going to have a stroke or another PE. So my hope is after today, we're going to go over some of the most recent evidence in the field that you will feel a little bit more reassured, like I feel a little bit more reassured, understanding what's the latest evidence to guide this high risk, high benefit therapy. I don't have any financial disclosures, but I am on the board of the Anticoagulation Forum, which is a fantastic organization that's really focused on improving the quality of anticoagulant care and also education. So every 2 weeks, they have a digest, a recap of the literature, which if you are an anticoag geek like me, I highly recommend you check out. And then the other disclosure I will say is that anticoagulation management is very nuanced. And there's going to be a lot of clinical situations that you just don't know what the right thing to do. You're just going to make your best informed guess. So I'm going to focus today on sort of the typical or standard patient understanding and acknowledging that in real life, sometimes there isn't evidence to guide our practice. What we're going to cover today, the first half of the talk, is going to look at antiplatelet medication use, either single or in combination with each other, or in combination with anticoagulants, and that's specifically for coronary and ischemic heart disease. We will then turn into updates in the direct oral anticoagulants, and I'm going to focus on the use of extended low-dose DOACs for venous thrombosis, and also a question, should you restart anticoagulation after an intracranial hemorrhage? And finally, a couple minutes on one of the new exciting developments in anticoagulation, which is the factor 11 and 11A inhibitors. All right, let's get started. So we're going to start with antiplatelet therapy. So antiplatelet therapy, which in this case I'm going to refer to aspirin or the P2Y12 inhibitors, the potent ones ticagrelor or prasugrel, and those less potent ones clopidogrel, they're commonly used in preventing adverse atherothrombotic events related to coronary disease. Starting with single antiplatelet. So you're using either aspirin or a P2Y12 inhibitor. Going over the categories of why you might use a single antiplatelet. First, let's talk about primary prevention. And guidelines have really evolved over time, but the latest recommendations are that primary prevention, meaning that they've not had a history of ischemic heart disease. Single antiplatelet therapy should only be reserved in those people who have a very high risk of developing an ischemic event and a very low risk for bleeding. And that actually excludes a significant number of people, in particular, people who are older and who will have a bleeding risk related to aspirin. Where single antiplatelet therapy is most commonly used is in the secondary prevention. So someone has had an ischemic heart event, and you're using either aspirin or a P2Y12 inhibitor to prevent another event from happening again. And that might be in stable or chronic coronary disease, that might be an ischemic stroke or TIA or peripheral arterial disease. When would you use dual antiplatelet therapy? And that is when you're combining aspirin plus a P2Y12 inhibitor. These are used in general for a shorter period of time during a period when there's a high risk of atherothrombotic outcomes, and most commonly in prevention of stent thrombosis after coronary stent, prevention after peripheral arterial stent. In some situations, you will also use acute coronary syndrome, acute MI for short duration after cerebrovascular events like minor strokes or TIA. And then in selected patients, you could consider using dual antiplatelet therapy for secondary prevention in the chronic setting in people who are particularly high risk of developing ischemic heart event. So let's focus on the most common use, which is after coronary stent. So we use strong double antiplatelet therapy to prevent coronary stent thrombosis. And this is uncommon, but we care about it a lot because it's associated with a high risk of mortality, high risk of adverse outcomes. Stent thrombosis can be categorized in the acute phase, which is within 24 hours after placement of a stent, in the subacute phase, which is within 30 days after placement of stent, and then there's later thrombosis, so after 30 days or after a year. And risk factors for thrombosis can be at the patient level, but also the procedural level. So if you had a complex PCI intervention with multiple stents and or long stent lengths, those are patients who might have a higher risk of developing a stent thrombosis. Standard recommendations from guidelines are that you would prescribe dual antiplatelet therapy, so strong platelet inhibition, for 12 months after the placement of a drug-eluting stent. Now, some of that data on stent thrombosis comes from older literature, and there are new developments in stent technology, which now the newer stents have a lower risk of acute stent thrombosis. And certainly when you combine antiplatelet agents together, you get a higher bleeding risk. And there have been some recent studies that have tried to minimize that time on dual antiplatelet therapy and showed non-inferior outcomes compared to just continuing on dual therapy. So a question is, can you get away with just using a single antiplatelet agent after placement of a stent? And this is the first trial that I'm going to talk about today. This is the NEO Mindset trial published earlier this year, multi-center, open label, randomized trial conducted in Brazil. They recruited people who had acute coronary syndrome, placement of a drug-eluting stent, and they looked at the question, could you get away with just using a single antiplatelet agent as opposed to using standard dual agent antiplatelets? So these were people who had acute coronary syndrome, either ST elevation MI, non-ST elevation MI, or unstable angina. They were excluded if there was planned additional coronary intervention or active bleeding. And then they recruited patients in the very early phase after stent placement within 4 days and randomized them to either single agent, so that was either ticagrelor or prasugrel, versus more conventional dual antiplatelet standard combination therapy with a P2Y12 inhibitor plus aspirin. And the primary outcomes were at 1 year. They looked at ischemic outcomes, so composite of death, and thrombotic outcomes like revascularization, MI, and stroke. And then the balancing outcomes, which was safety outcomes, bleeding, and major and clinically relevant non-major bleeding. Patients were well balanced, and you can see that the majority of people had STEMIs, smaller proportion with NSTEMIs, a small proportion with unstable angina, and a significant proportion, more than 40% in each arm, had multi-vessel coronary disease. So this is a higher risk population. And here are the outcomes. So this is the primary efficacy outcome. This is the thrombotic, death, MI after stent. And this trial showed that single agent antiplatelet therapy was not as effective as dual agent. So this confirmed our current practice of prescribing dual agent antiplatelet therapy immediately after stent. The risk at 1 year was 7% versus 5.5% in the dual agent arm. And concerningly, it's in that early phase, right after the placement of stent, where we saw a divergence in the rate of the adverse outcomes. In terms of safety outcomes, which is bleeding outcomes were better in the single agent arm compared to the double agent arm, 2% versus 4.9%. And the divergence of the bleeding risk really just kept diverging over time. It wasn't a time limited one around the time of the stent. When you dive a little deeper into the data in the study, you find a lot of it is in the early stent thrombosis. So in the single antiplatelet arm, there were 10 stent thromboses that occurred within 30 days, as opposed to 3 in the dual agent arm. Late stent thrombosis, so that's between 30 days and a year, were much less common, and no difference in all-cause death. So this study, the NEO-Mindset study, confirmed our current practice of using dual antiplatelet therapy right after PCI and stent. Its single therapy was not as effective as dual therapy, and it showed that there was a lot of early stent thrombosis if you're just using a single agent. And it supports what we do right now, which is dual agent therapy immediately after stent. So that's immediately after stent. What about 30 days after stent? And so I'm going to now move to our next trial, which is the Target First trial. And this was investigating, well, maybe you've gotten out of that 30-day window, the acute stent thrombosis risk. Can you get away with single agent therapy at that phase? So this was a multi-center open label randomized trial in Europe, and it recruited people with acute MI undergoing PCI drug-eluting stent on dual antiplatelet therapy as is recommended. And then at 30 days, they said, well, can we stop the aspirin and just do single agent P2Y12 inhibitor? These are people STEMI or NSTEMI, and importantly, these were somewhat lower risk patients. They all had complete revascularization on their PCI. All clinically significant lesions were addressed. And they also excluded those people who were at particularly high risk of having another atherothrombotic event. So they excluded people with complex PCIs, long stent lengths, left main disease. After 30 days of dual antiplatelet therapy, patients were then randomized to stop their aspirin and just continue P2Y12 inhibitor monotherapy, or to continue conventional dual antiplatelet therapy for the full 12 months. Again, the outcomes, a combination of the thrombotic outcomes, death, and bleeding. The patients in this study were well balanced in both arms, and about half and half were STEMI versus non-STEMI. Were recruited 37 days after the initial PCI, and the majority of them were on potent P2Y12 inhibitors, ticagrelor or prasugrel. All right, what are the outcomes show? So this is going to be in contrast to the first trial that we saw. So the Target First in this case found that single agent therapy with ticagrelor or prasugrel was non-inferior to dual agent antiplatelet therapy, and the overall net adverse event rate was 2.1 versus 2.2, met criteria for non-inferiority. And then when you look at stent thrombosis, the thing that we worry about, there was only 1 stent thrombosis in the single agent, 0 in the dual agent. The advantages, again, we see that single agent antiplatelet therapy has a lower risk of bleeding than dual agent, 2.6 versus 5.6. So the conclusions from the Target First trial are that if you select your patients correctly, so these are people who had a not complex PCI, who had complete revascularization, and even if they're having an MI and PCI, that stopping aspirin at 1 month was not inferior to continuing on dual antiplatelet therapy and had the advantage of a lower bleeding risk. Caveats, so these patients were carefully selected to be on the lower risk side. The majority of the patients were on the most potent P2Y12 inhibitors and had excellent adherence to their therapy. And the remainder of their medical therapy was very well optimized. So this is a selected population. So to review, what is our approach to antiplatelet therapy after acute coronary syndrome and PCI? Well, the weight of the available evidence still shows the benefits of dual antiplatelet therapy immediately after PCI and for the 1 month period, and that prevents subacute acute stent thrombosis. And then after the 1 month period, your decision is really driven by a person's bleeding risk and also their risk of recurrent ischemic events. So if your bleeding risk is low or your ischemic risk is high, then we would recommend, guidelines still recommend continuing dual antiplatelet therapy for the full year. But like in many of our patients, if you have an intermediate or higher bleeding risk, you can consider shorter periods of dual antiplatelet therapy. So intermediate bleeding risk, you could get away with a less potent P2Y12 inhibitor like clopidogrel plus aspirin, or even guidelines now suggest single agent ticagrelor is an option in your intermediate bleeding risk. And then in the people who have very high bleeding risk, you could consider after 1 month single agent P2Y12 inhibitor monotherapy. And then after 1 year, so when they enter into the chronic stable coronary disease, you should consider, again, de-escalating to the less potent platelet inhibition using aspirin. So that was a quick review of single agent, double agent antiplatelet therapy. We're now going to say, like, how do you combine antiplatelets and anticoagulants? And let's start first with an overview of the uses of oral anticoagulants. We have 3 main categories. We have warfarin, vitamin K antagonist. We have the direct thrombin inhibitor, dabigatran. And then we have the final category, the factor Xa inhibitors, which are the most commonly prescribed anticoagulants currently, apixaban, rivaroxaban, and edoxaban. Quick review of the indications for oral anticoagulants. Most common indications are for atrial fibrillation and stroke prevention and venous thrombosis, either in the therapeutic window or in the prevention of secondary recurrent VTE. And in both of these cases, either a DOAC or warfarin can be used, although DOACs are now preferred by guidelines because of a lower bleeding risk, and also it's much easier for patients to take. Reminder, there are still a few categories of patients where warfarin has better outcomes and is recommended over a DOAC, and those are people who have mechanical heart valves, people who have antiphospholipid syndrome, and those with rheumatic heart disease. But we're going to oftentimes run into situations where people both have an indication for an antiplatelet agent and an oral anticoagulant. And so what should you do in situations like this? And I'd like you all to think to yourselves about a pretty common clinical situation we might see in the hospital, which is someone who has an indication, a strong indication for oral anticoagulation, recent PE on apixaban, who then now has a strong indication for antiplatelet therapy, unstable angina, PCI, drug-eluting stent. So I'm going to have you think to yourself, what would you do with their antithrombotic therapy in this case? Would you say, oh, PCI, stent, dual antiplatelet therapy, I'm going to stop the anticoagulant, just use 2 antiplatelet therapies? Would you use combination therapy, which is you continue the anticoagulant and you just use 1 antiplatelet? Or would you use triple therapy, which is you continue the anticoagulant and you give dual antiplatelet therapy? So think to yourself, what would you do? And in this case, the recommendations are you do bite the bullet and you give triple therapy. So triple therapy, that's dual antiplatelet plus an anticoagulant. And it is used in the early phase because oral anticoagulants are not as effective at preventing stent thrombosis as antiplatelet agents. We do know that triple therapy significantly raises your bleeding risk. And so the goal is really to try to minimize the time that someone has to be on triple therapy. And the current guidelines are you range from 1 week to 1 month. 1 week for the low ischemic risk patients, 1 month for the people that have a higher ischemic risk. But then after 1 month, you should reconsider whether you need to continue on dual antiplatelet therapy. When using triple therapy, instead of using ticagrelor or prasugrel, you should use the weaker one, which is clopidogrel. And don't forget that you should minimize other sources of bleeding, and that would be gastroprotection, would be avoiding NSAIDs. All right, so here is a situation where you've now passed the triple therapy, maybe past the acute window, and you enter into chronic coronary disease. But they also had a history of ACS instead. What should you do in this situation with anticoagulants and antiplatelet? And this moves to our 3rd randomized trial for today, which is the aquatic trial, multi-center, double-blinded, placebo-controlled randomized trial in France. And this was looking at this question, okay, you have people who have indication for chronic anticoagulation, and they have a really strong indication for antiplatelet therapy too, in that they are at very high risk for ischemic heart disease, and they wanted to know whether adding aspirin to anticoagulants is the right decision, whether you improve overall outcomes. So these are people who had a high risk for recurrent coronary events, and these are people who had a prior PCI stent from 6 months onwards, or had diffuse multivessel disease, prior stent thrombosis, history of complex PCI. So these are selected high-risk people who you think would benefit from an antiplatelet agent. They also had an indication for anticoagulants, and they were randomized to combination aspirin plus anticoagulants or placebo plus anticoagulant. And the outcomes at 24 to 48 months were outcomes of cardiovascular, death, MI, coronary disease, stroke, and the balancing outcome of bleeding. So these are people who wasn't in the acute window after a PCI. The median time since their coronary intervention and stent was 3 years, although you will note that 28% of them had a PCI within the last 6 to 12 months. Many of them had a history of MI. Some of them had CABG. And the main reason why they were on oral anticoagulants were AFib. So this is a pretty common situation that you encounter in clinical practice. What did they find? Well, this trial was stopped early because they found that the addition of aspirin to an oral anticoagulant actually led to worse efficacy outcomes. So even though you thought that adding aspirin is going to prevent more of the cardiovascular events, in fact, the overall rate of adverse outcomes was higher with combination therapy, 16.9% versus 12.1%. Not surprisingly, it also led to more bleeding, 10.2% versus 3.4% in the anticoagulant alone, and more death, so 13.4% versus 8.4%. So this trial showed that combining aspirin and oral anticoagulants, even in people who you think would really benefit from it, actually led to worse outcomes. And part of it is these are people who had chronic coronary disease. Even if they were after PCI, the risk of late stent thrombosis is quite low, and there was a significant risk of major bleeding and overall death. So this trial, in addition to the accumulating evidence, really, really strongly advises us against combining aspirin and anticoagulant therapy for chronic coronary disease. So here's an overview of the approach of how to combine antiplatelets and anticoagulants. Still, there is an indication in that very early window after PCI and stent. So if you have to be on an anticoagulant and you get a PCI and stent, you do triple therapy for up to 4 weeks. But then after that, de-escalate therapy to anticoagulant plus a single antiplatelet agent, a weaker one like clopidogrel or even to aspirin. And then make sure at 1 year, you try to take off the aspirin or the antiplatelet and just do monotherapy with oral anticoagulants. In people with even higher bleeding risk than average, you could try to shorten that period of combination antiplatelet anticoagulant therapy. Again, you still need that initial few weeks of triple therapy, but then up to 6 months, dual therapy with anticoagulant antiplatelet. And then after 6 months, consider oral anticoagulant only. So we talked about starting anticoagulants in someone who's on chronic antiplatelet therapy. This is a quick review quiz. So let's say you had a PCI stent 2 years ago on aspirin, appropriately now diagnosed with AFib. What are you going to do? Only anticoagulant. So take home point. All right. What if the situation is reversed? So now you're in someone who is on chronic antiplatelet therapy and now has a new indication for anticoagulant. I'm going to go over the approach to this. So if the antiplatelet was just for primary prevention, that was a weak indication to begin with. And if they develop an indication for oral anticoagulants, you should definitely stop the antiplatelet, just use the oral anticoagulant. For secondary prevention, stable chronic coronary disease, that was like the patients in the aquatic trial that we just talked about. you should strongly consider stopping the antiplatelet and using oral anticoagulant alone. And then the final category is those people with more recent acute coronary syndrome. Those are the people that could still remain on combination therapy, but make sure that you follow up with this patient and de-escalate therapy when it comes time. Okay, take-home points. Single agent, double agent anticoagulants. So a reminder, after PCI and stent, use dual agent antiplatelet therapy to prevent stent thrombosis. Single agent is not as effective. But after 30 days in carefully selected low-risk patients, you could de-escalate to just a single P2Y12 inhibitor. If you are in a situation where you have to combine anticoagulant and antiplatelet therapy, triple therapy is still necessary for a short period of time right after PCI and stent, but you should minimize that time to 1 to 4 weeks. And then after that, de-escalate to combination therapy for the 6 to 12 month range. And after that, strongly consider deprescribing the aspirin and just remaining on anticoagulant monotherapy. All right, that was antiplatelets. We're now going to move on to anticoagulants. Updates in the direct oral anticoagulants, and we're going to talk about a couple trials that are examining extended VTE prevention using low-dose direct oral anticoagulants. We're also going to talk about a trial that looked at restarting DOACs after intracranial hemorrhage. So I want you to think to yourself about situations with venous thrombosis. And after you've already treated their acute thrombosis with full dose therapeutic anticoagulation, there's an option to step down to reduce the dose of DOAC and use low dose DOAC therapy. When would you do this? What if it's a person who developed a DVT and didn't have any identifiable risk factors, what we used to call unprovoked DVT? Do you use extended low-dose anticoagulants? What about it's someone who has metastatic active cancer, already finished their therapeutic anticoagulation for cancer-associated VTE, they're at high risk, can you go to a low-dose DOAC? Or what about the opposite situation? People who we traditionally have had self-limited 3 months of anticoagulation and then stop. This is a person who developed a PE after a major surgical event, completed the 3 months that you would usually stop. Who would use low-dose anticoagulation? So I'm going to go over some of the more recent evidence that is looking at this spectrum of risk of patients who have VTE and the use of low-dose DOACs. But first, just to review that after the initial treatment phase with therapeutic anticoagulation, there's this period of where you want to prevent recurrent VTE, secondary prevention of VTE. And guidelines do not recommend extending that therapy for people with the provoked VTE, so the people who have that transient, major, reversible event like surgery or immobility. Conversely, people who have the higher range of risk of VTE are those people who had no identifiable provoking risk factors or a very strong persistent risk factor like active cancer, active thrombophilia. And in selected patients with unprovoked VTE, there is evidence that reducing that dose of DOACs and extending that therapy led to good outcomes in terms of low bleeding rates and also a lower risk of recurrent VTE. And so that's instead of using the 5 milligrams BID of apixaban, you use 2.5 milligrams BID, or instead of using the full 20 milligrams of rivaroxaban, you use 10 milligrams of rivaroxaban. So that's reduced dose DOACs. And there are 3 trials that were published in the last year that have addressed both of these spectrums of risk. The people who had very high risk, the people that you would have generally kept on extended full dose anticoagulation. And then one trial that looked at people that guidelines generally recommended stopping anticoagulation after 3 months, after the provoked event. So we're going to go over these 3 trials and start with the RENOVE trial, which is a multi-center randomized non-inferiority trial in France. And it recruited people who had an acute VTE and were considered to be at persistently elevated risk. So they had to have completed between 6 and 24 months of full dose anticoagulation. And then the study investigators wanted to look at the question of whether you could get away with low-dose DOAC as opposed to continuing full-dose DOAC. These were people who had acute VTE, a high risk for recurrence, and the high risk for recurrence is a mix of different factors, but it could be people who didn't have a known risk factor for VTE, people who had recurrent VTE or thrombophilia, family history of VTE, or ongoing underlying persistent risk factors, and that included cancer, although they excluded people who had active cancer within the last 6 months. All of these people had their VTE, they completed their initial therapeutic dose, and then were randomized to either low-dose DOAC, either apixaban or rivaroxaban, or continuation of full-dose DOAC. And over a 5-year period, the investigators followed the outcomes we care about, which are recurrent VTE, as well as the safety outcomes, major and clinically relevant non-major bleeding. What do these patients look like? So most of them, their index event was acute PE. Small but significant proportion had a history of cancer. Many of them had recurrent VTE events. Many of them had a diagnosed history of thrombophilia. And all of them were kind of in that, they had finished their therapeutic anticoagulation, 8 months of full dose anticoagulation. So what did the RENOVE trial find? Low dose versus full dose. Low dose didn't actually meet the criteria for non-inferiority, but I think a part of that was because the VTE rates were quite low in both arms. So this over a 5-year period, these are high-risk patients. And the recurrent VTE rate in the low dose was 2.2, in the therapeutic dose was 1.8. Low dose did have an advantage of having lower bleeding risk, 9.9% bleeding risk in the low dose, 15.2% in the full dose. So that was the RENOVE trial with a sort of a mixed bag of conditions that elevate your VTE risk. What about for cancer? And we're going to go into the second trial, which is the APICAT trial. This is a multi-center, double-blinded, randomized, non-inferiority trial in Europe. And this specifically looked at what we have traditionally thought about as you stay on full-dose anticoagulation indefinitely. These are people who have active cancer and cancer-associated acute VTE. Everyone finished their first 6 months of therapeutic anticoagulation. And this study looked at the question, can you get away with low-dose apixaban as opposed to continuing therapeutic dose apixaban? Acute VTE, active cancer, finished 6 months of therapy, and then half randomized to the 2.5 BID apixaban, half randomized to full dose. And this was a follow-up of 1 year looking at the outcomes we care about, recurrent VTE and bleeding. Looking at the patients in this trial, the majority of patients, similar to the RENOVE trial, had acute PE as their index event. Many of them had a prior history of VTE, and the most common kinds of cancer in the participants were breast cancer, followed by colorectal cancer and lung cancer. Here are the outcomes. So for efficacy outcomes, looking at recurrent symptomatic VTE, low dose was non-inferior to full dose in preventing recurrent VTE. The rates were 2.1 versus 2.8%. And then bleeding rates looked favorable. So low dose had a lower bleeding risk than the full dose. That was 12.1 versus 15.6. And this was a 1-year trial. These bleeding rates are significantly higher than in the other trial, the RENOVE trial. So a reminder to us all that people who have cancer have a higher risk both of VTE and of bleeding. So how do we merge these two trials together? So the question, these were patients that many of us would have just continued full dose, indefinite therapeutic anticoagulation. And both the RENOVE and the APICAT, I think, reassure me that even in these people with the higher risk of recurrent VTE, that low dose therapy is a reasonable option and has the advantage of reducing bleeding risk. So that was the high risk patients. We're now moving to the low risk patients. So I'm going to call them provoked versus unprovoked VTE, although really the nomenclature has evolved over time. to talk more about major and minor, transient, persistent risk factors. But very commonly, they're still referred to as provoked events, meaning that there is some major inciting event, or unprovoked, which you can't find out why they developed a clot. And part of the reasons why provoked and unprovoked kind of stayed around is because guidelines were oriented around that in saying that provoked events, the risk of recurrent VTE was quite low, so you can get away with 3 months of self-limited anticoagulant therapy and then stop it. And unprovoked, for some reason, they have a persistently high risk of VTE. You should stay on anticoagulants for indefinitely. I think a more nuanced approach to thinking about VTE recurrence risk is really as a spectrum, though. And when you think about different risk factors, they can fall into the strong versus weak associated factors, or the transient, ones that are going to go away, they're reversible, versus the ones that are persistent or ongoing. And then there are a lot of patients who have combinations of risk factors. So VTE recurrence risk should really be viewed as a gradient of risk. And I think that helps us guide the duration of therapy. This table comes from the ESC 2019 guidelines. I think just the take home is that you can have gradients of risk ranging from the very low risk. Those are people who don't have underlying conditions, who have a very strong inciting effect like orthopedic surgery that's prompting their VTE. Their risk of recurrence is quite low, less than 3%. There's an intermediate risk. Those are people who have less strong provoking events, that maybe like long haul travel or hormonal therapy, or maybe a weaker underlying medical condition like chronic inflammatory or autoimmune conditions, all the way to the very high risk of recurrence, more than 10% per year, active cancer, strong thrombophilias, recurrent unexplained VTEs. So this trial was published recently. This is a HiPro trial, and it looked at a category of patients that we don't conventionally think of as extending their VTE prevention strategy. So this is looking at the question, should you give extended anticoagulants, low-dose anticoagulants, in people who had a provoked VTE, categorized as provoked? It was a single-center, randomized, double-blinded, placebo-controlled trial conducted at the Brigham, and recruited people who had what was thought to be a provoked VTE. So that was like surgery, immobility, medical illness, or immobility. They completed their initial 3 months of therapeutic anticoagulation. And usually those are the people that you would stop. But they did recruit for people who the investigators thought had a higher risk of having a recurrent clot. So these had at least one enduring risk factor for VTE. Enduring risk factors for VTE, we see this all the time. So this is a very broad range of risk factors. Persistent immobility, using a wheelchair, or paralysis, or difficulty ambulating, obesity, chronic inflammatory or autoimmune conditions, and it didn't matter if it was active, it's the history of it, chronic kidney disease, chronic lung disease, like a history of asthma or COPD, or atherosclerotic cardiovascular disease or heart failure. So this is a very broad range of patients that traditionally you would have just said they had a provoked VTE and you would stop. So these people, provoked VTE, enduring risk factor, randomized to low-dose apixaban, 2.5 milligrams BID, or to placebo. And at 1 year, looked at the outcomes, recurrent VTE, major bleeding, and then also clinically relevant non-major bleeding. These people, they kind of looked like the patients that we take care of in the hospital. A lot of them with PE, a lot of them with a variety of these different provoking factors, acute medical illness or surgery, some trauma, some long-haul travel, and a mix of enduring risk factors. So half of them who had a BMI of greater than 30, half of them with some chronic inflammatory or autoimmune condition, but a decent number with chronic lung disease and cardiovascular disease. All right, so what happened? Low dose apixaban really reduced, like by 87%, the risk of recurrent VTE at 1 year. 10% in the placebo arm and 1.3 in the low dose apixaban arm. One striking thing was that so they selected patients who were at really high risk for recurrent VTE, 10%. So that's a lot higher than we usually think of when we think about your average provoked VTE. In terms of the safety outcomes of apixaban, major bleeding rates were low and not statistically significant between the two, 0.3 versus 0% in the placebo arm. But numerically, there were more clinically relevant non-major bleeding in the low-dose apixaban arm. That was 4.8% versus 1.7%. All right, so how do you take this together? So these are patients who are not your necessarily typical what you think about when you say provoked VTE, low risk for recurrence. These were selected to have a higher baseline risk of recurrence. And in these patients, kind of similar to Apicat and Renove, low dose DOAC looked effective at preventing recurrent VTE with a low risk of major bleeding, but some numerically higher risk of minor bleeding. And I think the way I take this trial is that this just supports them that we should approach estimating VTE risk with a greater degree of nuance than simply provoked 3 months, unprovoked, lifelong. So how do I put all of these together? I think another take home is that anticoagulants work. Anticoagulants really reduce the risk of clot. And the good news is that low dose anticoagulants seem comparable in terms of reducing VTE, and they are significantly safer than full dose anticoagulants when you're looking at extended therapy. So now you must be wondering, well, do you just keep everybody on anticoagulants for the rest of their life? And a cautionary tale here. So this is a Markov model based study, a cost-effectiveness study published a couple years ago that looked to see what were the benefits in terms of quality-adjusted life years as well as cost-effectiveness if you just prescribed indefinite anticoagulation for someone who had unprovoked VTE first time. The rate of recurrence was kind of average, so that they estimated 6% recurrent risk of DVT, 3% of PE, annual rate of bleeding 1%. And this is the cautionary tale. Indefinite anticoagulation, yes, it prevents VTE, but at the consequence with a lot of major bleeding, and sometimes those major bleedings are intracranial hemorrhages and fatal bleeding, and cumulatively together, you increase costs by $16,000 Canadian in the study without improving quality of life. So you're increasing costs, not improving quality of life if you're just indiscriminately prescribing indefinite anticoagulation. This study, however, was conducted using the assumptions on full dose anticoagulation. And if you change things and you really lower the bleeding risk, or you pick patients who had a higher risk of recurrence, you might tip that balance. So I'll be looking forward to seeing the follow-up modeling study to this one. So here is a general approach to how do you estimate duration and dose of anticoagulants for acute VTE. So acute VTE, you should still have your initial full dose therapeutic anticoagulation course for 3 to 6 months. Always, you think about patient factors, bleeding risk, shared decision-making, barriers to being able to afford anticoagulants. But then beyond that, and when you're thinking about duration of anticoagulation therapy, think about a more nuanced spectrum of VTE risk that ranges from high bleeding risk or high risk for recurrence all the way to the low risk. If you are at the low risk for recurrence, less than 3% per year, those are the people who don't have the enduring risk factors. They had a really strong major inciting event like major surgery. Those are the people I'm confident you can stop anticoagulants. Intermediate risk. So this is more like high pro study. Those are people who maybe have a few combination of minor or reversible or persistent risk factors, or maybe they had what was called unprovoked VTE. You can't explain why they had it. They fall in that middle category. And those are people I would consider talking with the patient and suggesting extended therapy with a low dose anticoagulant to minimize the bleeding risk. And then there are people in the high bleeding or the high recurrent VTE risk category. Now, some people you like strong thrombophilias, antiphospholipid antibody syndrome, they should stay on therapeutic anticoagulant. But we saw some evidence that some categories of patients who previously would have been on full dose anticoagulants, cancer, or a higher baseline risk of recurrence, maybe you can get away with using low dose extended anticoagulation therapy as an alternative. All right, our last trial on DOACs. So this one I'm just going to have you think to yourself. You have someone who has a high risk of stroke. So they have atrial fibrillation, high transvasc on anticoagulants. Then unfortunately, she develops an intracranial hemorrhage. You hold the DOAC, she recovers, she's fine at baseline. And now, months later, you're stuck with the decision, how do you balance the risk of recurrent hemorrhage versus preventing stroke? So think to yourself, which one would you do? Would you say, I'm going to restart the anticoagulant because her risk of stroke is high? Or you would say, no, she had an intracranial hemorrhage. That's a contraindication. I wouldn't restart it. I'm going to go over this trial that is the Prestige AF trial that actually randomized people to restarting versus not restarting anticoagulants after intracranial hemorrhage. So intracranial hemorrhage, this is even worse than stroke. Like the complication is actually worse than the thing you're trying to prevent. And it is why I really worry about starting anticoagulants on my patients. DOACs have a lower risk of intracranial hemorrhage than on warfarin. And some of the recent observational data and the meta-analysis have been reassuring, saying, oh, you know what, in balance, restarting the anticoagulant actually leads to net better outcomes in these people, even if they've had intracranial hemorrhage. But observational studies are subject to selection of patients and bias, and they're probably lower risk, healthier patients to begin with. So I really like this trial because they randomized it, and so you have higher quality evidence to guide your decision making. Multi-center randomized non-inferiority trial that recruited people with AFib, indication for anticoagulants, who developed a spontaneous intracerebral hemorrhage, and they had to have recovered and had a period off anticoagulants, and then were randomized to either a full dose anticoagulant with a DOAC versus no anticoagulation. And they looked at a variety of outcomes, but the ones that we care about most are stroke from AFib, intracranial hemorrhage recurrence from anticoagulation. The people had a mix of different types of hemorrhage, lobar versus non-lobar. Many of them had been on anticoagulants before. All of them had a high stroke risk. So what do we find? In terms of primary outcome, it's reassuring. You give an anticoagulant, you can prevent stroke. 1 stroke in the DOAC arm, 20 strokes in the no DOAC arm. But recurrent ICH, significantly higher in the DOAC arm, 11 versus 1 in the no DOAC arm. And major bleeding, higher in the anticoagulant, that was driven a lot by the recurrent intracranial hemorrhage. All-cause death, no statistically significant difference. So the number needed to treat to prevent 1 stroke was 13. But the number needed to harm to create 1 intracranial hemorrhage was 24. And I would argue that that's actually not a great ratio. So it doesn't really help reassure me that starting anticoagulants after an intracranial hemorrhage is the right thing to do. So this study, it was small, but it did show that anticoagulants work in preventing stroke, and anticoagulants have a consequence of making more intracranial hemorrhages. And the way I have interpreted it is that I'm still extremely cautious about anticoagulating after intracranial hemorrhage. It's with a lot of shared decision making, and you have to go into it with your eyes open. And you should consider alternative options for reducing stroke risk in AFib that do not involve anticoagulants. All right, I'm going to spend the last few minutes of this talk going over, and I see other experts in the audience will know a lot more about this. So I'm just going to do it at the internist level, the hospitalist level, which is the factor 11 and 11A inhibitors. So the crux of this, so we talked about you give an anticoagulant and you prevent a bad clot. You give an anticoagulant, you create bleeding. And the exciting thing about this new category of anticoagulants is trying to test this possibility that you could unlink thrombosis and hemostasis. So thrombosis is something, it's from the intrinsic pathway. It's this thrombus generation, amplification that is in response to foreign bodies or inflammation. That's what we want to prevent, like DVT, PE. As opposed to hemostasis, which is you cut yourself, there's tissue factor, and your body wants to stop that. That's good clot. So bad clot, good clot. And the key and why factor 11 is very intriguing is that factor 11 seems to mediate the thrombosis part, but not the hemostasis part. So it is supported by some observational data that people with inherited factor 11 deficiency, they have a low risk for thrombosis, but also low risk for bleeding. And so there's been a lot of effort to try to say, can you prevent the bad clots while allowing for good clots, hemostasis, to form? And that would be good in all patients, of course, but particularly important in people who have a higher risk of developing clots and bleeding. And that might be people with high bleeding risk, with foreign bodies, like medical devices, end-stage kidney disease. So there's a lot of hope in the practical applications of this. Here is just a quick snapshot of categories of factor 11 and 11A inhibitors that are in development. They range from the monoclonal antibodies to the small molecule inhibitors, all the way to the DNA antisense oligonucleotides. I'm going to focus on the latest evidence, the clinical trials that were published earlier this year, abelacimab and asundexian. And these are two trials, the Oceanic AF, which is asundexian versus apixaban in AFib, and the Azalea TIMI 71, which is abelacimab versus rivaroxaban in AFib. Starting with Oceanic AF. So asundexian, orally administered direct 11A inhibitor, and it was built off the Pacific AF trial, which initially showed some favorable safety outcomes in comparison to apixaban and AFib. This was a large, multi-center, randomized controlled trial that was really looking at the efficacy of this agent. And these were people who had AFib and a high stroke risk, randomized to asundexian versus conventional DOAC, apixaban, and looking at the outcomes that we care about, stroke and embolism versus bleeding. You can see here that this is your high-risk group of patients with AFib. Many of them had prior stroke or TIA. And this trial actually was a big disappointment. It was stopped early because efficacy outcomes was not as good in the asundexian arm. 3.9 per 100 person years in the asundexian arm versus 1 in the apixaban arm, so it didn't work. Bleeding, so it was favorable, so lower bleeding risk than apixaban and no overall difference in death. So Oceanic AF was disappointing because yes, it was safer, but it also didn't work. So it did not meet non-inferior criteria, and there was a lot of thinking about why was this. And one of them is challenging maybe our base assumption that maybe like factor 11 inhibition doesn't actually protect you against developing stroke. So that would be one possibility. But others said maybe the dosing that was used in the study was too low. And so maybe you needed higher than what they achieved in terms of factor 11 in activity inhibition. So that brings us to the other trial, which was Azalea TIMI 71, looking at a different inhibitor, which is a monoclonal antibody administered once monthly as a subcutaneous injection. And some of the preliminary studies were favorable, looking at prevention of VTE after knee arthroplasty. And in a head-to-head comparison of abelacimab versus enoxaparin, it had low VTE risk and didn't increase bleeding. So this study, also in AFib patients like Oceanic AF, multi-center randomized controlled, it was a phase 2B trial. So this, unlike Oceanic AF, which is looking at efficacy, stroke prevention, this one is an earlier one that's looking at safety outcomes. Patients who had AFib, high risk for stroke, they looked at 2 doses of abelacimab versus rivaroxaban in the study. And then their primary outcome was the safety, just as a reminder. 1,280 patients with AFib, divided into 3 separate arms with good distribution of risk factors, many of them with a very high CHA2DS2-VASc score and a history of prior stroke. This trial too was ended early, but for the opposite reasons. Again, this was a safety trial, and this trial ended early because abelacimab looked safer than rivaroxaban. And in both of the doses of abelacimab, you had a lower risk of bleeding. When you look at the type of bleeding, you can see the rates here in rivaroxaban, the rates of major, non-major bleeding, 8.4 versus 2 to 3 in the abelacimab arms, and a significantly lower risk of major GI bleeding. What I would also look at, however, is the rates of stroke and systemic embolism. Understanding that this was not an efficacy trial, but it did strike me that the rates of stroke and embolism were higher in the abelacimab arm compared to the rivaroxaban arm. So this study found, again, a safety trial that found abelacimab was safer than rivaroxaban, especially in GI bleeding. Caution, it is not designed to compare efficacy, and there are several trials that we're all eagerly awaiting to see, again, will these factor 11 and 11A inhibitors actually pan out in terms of doing what we want them to do, preventing thrombosis. All right, quick recap of a very packed session today. We talked about single agent versus dual agent antiplatelets. And take-homes are, you should still use dual agent antiplatelet therapy to prevent early stent thrombosis after PCI. But then in selected patients after 30 days, you can consider stopping the aspirin and just using a P2Y12 inhibitor. When you have to be in the unfortunate situation of combining anticoagulant and antiplatelet medications, you do have to use triple therapy sometimes, but you use it for a time-limited period, no longer than 4 weeks, and then limit combination therapy, just a single antiplatelet and anticoagulant to no more than 6 to 12 months, and then strongly consider de-escalating to just anticoagulant monotherapy for chronic coronary disease. We also talked about the use of extended anticoagulation, the use of low-dose DOACs as an alternative to full dose in the prevention of recurrent VTE. And it is an option in people who have an elevated risk of recurrent VTE, even in people with cancer. And for selected patients, the provoked VTE doesn't automatically say that you should get 3 months and then stop. Think about what other risk factors that might increase that person's baseline risk of VTE. We talked about restarting anticoagulation after ICH. Personally, I would do it only with extreme caution. And then finally, we're all still waiting for the magic bullet of being able to de-leak thrombosis and hemostasis. Preliminary evidence looks like it's safer. I think the jury is still out on whether they work or not. Thank you so much. I'd be very happy to take one question.
Thank you for that action-packed and acronym-packed talk. We have time for one question. Any questions from the audience?
I've noticed when I'm doing med rec in the hospital, the dose of apixaban for AFib keeps getting lower. I've just gotten used to the 2.5 and those indications, and then BID. And then sometimes you'll see a patient come in on 2.5 daily, and you read the notes, or I even had a 2.5 every other day. So I'm curious what you think of this lowering of the dose of apixaban for AFib or other DOACs for AFib.
That is a great question, and I will just say, in studies that have looked at low dose apixaban versus full dose in atrial fibrillation, low dose is worse outcomes. So don't do it, or at least do it very, very cautiously. And we actually did a study a couple of years ago here at UCSF that looked to see who was getting the low dose apixaban for AFib, and it wasn't always just the people who met the criteria. There was a lot of people who are just worried about the bleeding risk, or maybe they're older, frailer, and I think I'm going to give this person, less bleeding and equal efficacy. I would say that most of the studies, meta-analysis, they all show that if you're choosing low dose, your outcomes are worse. There may be one or two situations where you can get the anti-10A levels and try to estimate what's the therapeutic range, but that so far is not yet linked to hard outcomes.
Can you remind us what are the limb indications?
All right, so doses for apixaban. So when you think about apixaban or DOACs in AFib, so that's one big category, and then VTE is the separate category. So for apixaban and rivaroxaban in AFib, would strongly recommend the FDA-approved dosing label, and that's full dose for people who meet categories, or if the age, weight, and kidney function, you might lower the dose for the apixaban to 2.5 milligrams BID. I have not seen evidence that single daily dose of apixaban is effective. It would be those are the people that the outcomes are worse, and it's probably also reflecting clinician uncertainty. So that's again 5 milligrams BID for AFib, except if you meet certain criteria. Now for VT, this is where we've gone over. So there's the treatment phase, which is the higher dose 10 milligrams BID, followed by the sort of maintenance therapeutic, which is 5 milligrams BID. And then what we've talked about is the secondary prevention of VTE, which is you could do the low dose DOAC for extended therapy for VTE. And that seems to be a reasonable compromise.
Great. Thank you so much. And we'll see you all next week.